Question 1. Benchmark analysis indicates that public health policies regarding routine cervical cancer screening have evolved, with varying recommendations from national organizations. A practicing obstetrician gynecologist in the United States is reviewing current patient management protocols. Considering the regulatory framework and guidelines relevant to the American Board of Obstetrics and Gynecology, which of the following approaches best reflects current best practices for cervical cancer screening in the general adult female population? Option A. Implementing a universal annual Papanicoleo (PAP) smear screening for all adult women, regardless of age or prior screening history, to maximize early detection. Option B. Prioritizing screening only for patients who express a personal concern about cervical cancer, as mandated by recent legislative changes aimed at reducing unnecessary medical procedures. Option C. Adhering to the most recent guidelines issued by the Centers for Disease Control and Prevention (CDC) and the American College of Obstetricians and Gynecologists (ACOG), which emphasize shared decision-making with patients regarding screening intervals and methods based on age and risk factors. Option D. Continuing to follow the screening schedule that was standard practice 5 years ago, as it has historically been effective and familiar to both the physician and patients. Correct answer is C. Adhering to the most recent guidelines issued by the Centers for Disease Control and Prevention (CDC) and the American College of Obstetricians and Gynecologists (ACOG), which emphasize shared decision-making with patients regarding screening intervals and methods based on age and risk factors. Explanation: this scenario presents a professional challenge due to the complex interplay between evolving public health policies, established clinical guidelines, and the ethical imperative to provide equitable patient care. The physician must navigate differing recommendations from national public health bodies and professional organizations, while also considering the practical implications for their patient population, which may have unique socioeconomic or access to care challenges. The core difficulty lies in reconciling potentially conflicting directives and ensuring that patient well-being and informed consent remain paramount, even when faced with resource limitations or policy ambiguities. The correct approach represents best professional practice because it prioritizes evidence-based decision-making, patient autonomy, and adherence to the most current and authoritative guidelines, while also acknowledging and addressing potential disparities in access. This involves a thorough understanding of the scientific basis for public health recommendations, the ethical principles guiding medical practice, such as beneficence and non-maleficence, and the legal framework governing healthcare delivery in the United States. It also necessitates proactive communication with patients about the rationale behind recommended interventions and any associated uncertainties or limitations. An incorrect approach that focuses solely on outdated guidelines fails to uphold the principle of providing the most current and effective care, potentially exposing patients to suboptimal outcomes. This represents a regulatory and ethical failure to adhere to evolving standards of practice. Another incorrect approach that disregards established public health recommendations without a strong clinical justification risks undermining public health efforts and potentially leading to poorer population-level health outcomes, which is an ethical lapse. Furthermore, an approach that ignores the socioeconomic factors influencing patient access to recommended interventions fails to address health equity, a critical ethical and increasingly regulatory concern in U.S. healthcare. The professional decision-making process for similar situations should involve a systematic evaluation of available evidence, including recommendations from bodies like the CDC and ACOG. It requires a critical assessment of the applicability of these recommendations to the specific patient population, considering factors such as insurance coverage, geographic location, and cultural beliefs. Open and honest communication with patients about the benefits, risks, and alternatives to recommended interventions is essential, ensuring informed consent. When policy recommendations conflict with clinical best practices or patient needs, physicians should advocate for their patients and engage in ethical deliberation, documenting their reasoning clearly. Question 2. The efficiency study reveals that the current protocol for managing patients with suspected preeclampsia with severe features is leading to delays in specialist consultation and initiation of treatment. Which of the following adjustments to the protocol would best optimize patient care and adhere to best practices in high-risk pregnancy management? Option A. Establish a tiered system where specialist consultation is only initiated for patients who have failed initial management by the primary obstetrician, aiming to streamline the referral process. Option B. Require the primary obstetrician to independently manage all cases of suspected preeclampsia with severe features, only escalating to specialists if the patient's condition deteriorates significantly, to reduce consultation overhead. Option C. Implement a mandatory, immediate multidisciplinary team huddle upon diagnosis of suspected preeclampsia with severe features, involving obstetrics, maternal-fetal medicine, anesthesia, and neonatology, to collaboratively develop a management plan and assign responsibilities. Option D. Prioritize the use of less expensive, non-specialist diagnostic tests and conservative management strategies for all suspected cases of preeclampsia with severe features to minimize healthcare costs. The correct answer is C. Implement a mandatory, immediate multidisciplinary team huddle upon diagnosis of suspected preeclampsia with severe features, involving obstetrics, maternal-fetal medicine, anesthesia, and neonatology, to collaboratively develop a management plan and assign responsibilities. Explanation. This scenario presents a professional challenge due to the inherent complexity and potential for adverse outcomes in managing high-risk pregnancies. Need for timely and accurate diagnosis, appropriate intervention, and seamless coordination of care among multiple specialists is paramount. Failure in any of these areas can lead to significant maternal and fetal morbidity or mortality, underscoring the critical importance of efficient and evidence-based processes. The correct approach represents best professional practice by prioritizing a multidisciplinary team-based strategy for managing complex cases. This aligns with established guidelines for high-risk obstetrics, emphasizing collaborative decision-making, clear communication pathways, and standardized protocols. Such an approach ensures that all relevant expertise is brought to bear on the patient's care, minimizing delays and optimizing outcomes. This is supported by the American College of Obstetricians and Gynecologists, ACOG guidelines, which advocate for comprehensive management plans developed by a team of specialists when indicated. An incorrect approach that relies solely on the primary obstetrician's judgment without adequate consultation or a structured referral process fails to leverage the full spectrum of expertise available. This can lead to diagnostic errors, delayed interventions, or suboptimal management strategies, potentially violating the standard of care and ethical obligations to provide the highest quality of care. Another incorrect approach, focusing on cost containment as the primary driver for management decisions, directly contravenes ethical principles and regulatory expectations that patient well-being and safety must always take precedence over financial considerations. This could lead to inadequate diagnostic workups or the avoidance of necessary, albeit expensive, interventions, thereby compromising patient care and potentially violating malpractice standards. A third incorrect approach, characterized by a lack of standardized protocols for high-risk pregnancies, introduces variability and unpredictability into patient care. This increases the likelihood of errors, omissions, and inconsistent management, which is contrary to the principles of quality improvement and patient safety promoted by regulatory bodies and professional organizations. Professional decision-making in such situations requires a systematic evaluation of the patient's condition, identification of potential risks, and the application of evidence-based guidelines. It involves proactive consultation with specialists, clear documentation of the rationale for management decisions, and open communication with the patient and her family. The process should be guided by a commitment to patient safety, ethical practice, and adherence to the highest standards of obstetric care, as defined by professional bodies like ACOG. Question 3. Comparative studies suggest that, while many instances of perceived decreased fetal movement in normal pregnancy are benign, a subset represents a critical warning sign. A 32-year-old G2P1 at 36 weeks gestation presents to your clinic reporting she has felt her baby move significantly less over the past 24 hours. She denies vaginal bleeding, abdominal pain, or leakage of fluid. Her previous pregnancy was uncomplicated. What is the most appropriate initial management strategy? Option A. Immediately perform a non-stress test (NST) and consider ultrasound assessment of amniotic fluid index (FE) and fetal biophysical profile (BPP). Option B. Advise the patient to drink a cold beverage and lie on her left side for 1 hour, then report back if fetal movements do not increase. Option C. Reassure the patient and schedule a routine follow-up appointment in 1 week, advising her to call if the movements decrease further. Option D. Refer the patient to the emergency department for immediate admission and continuous fetal monitoring. The correct answer is C. Reassure the patient and schedule a routine follow-up appointment in 1 week, advising her to call if the movements decrease further. Explanation. Scenario analysis. This scenario presents a common clinical situation where a pregnant patient expresses concerns about fetal movements. The professional challenge lies in balancing the patient's subjective experience with objective clinical assessment and established guidelines for managing potential fetal compromise. It requires careful communication, thorough evaluation, and adherence to evidence-based practice to ensure maternal and fetal well-being, without causing undue alarm or unnecessary intervention. The decision-making process is complex because, while decreased fetal movement can be a sign of distress, it can also be a normal variation or due to maternal factors. Correct approach analysis. The correct approach represents best professional practice by prioritizing a comprehensive and systematic evaluation of the patient's concern. This aligns with the American Board of Obstetrics and Gynecology, ABOG standards, which emphasize thorough patient assessment and adherence to evidence-based management protocols for normal pregnancy. Specifically, the approach involves immediate assessment of fetal well-being through methods like fetal heart rate monitoring and potentially ultrasound, while also gathering a detailed maternal history and performing a physical examination. This comprehensive approach ensures that potential risks are identified and addressed promptly and appropriately, reflecting a commitment to patient safety and optimal outcomes as expected by ABOG. Incorrect approaches analysis. One incorrect approach involves dismissing the patient's concern based solely on the absence of overt signs of distress or a history of previous uncomplicated pregnancies. This fails to acknowledge the potential seriousness of decreased fetal movement as a warning sign and violates the ethical principle of patient-centered care, which mandates taking all patient complaints seriously. It also disregards established clinical guidelines that recommend prompt evaluation of decreased fetal movements, potentially leading to delayed diagnosis of fetal compromise. Another incorrect approach is to immediately proceed with invasive interventions without a thorough initial assessment. This could lead to unnecessary medicalization of pregnancy, increased patient anxiety, and potential iatrogenic complications. It deviates from the principle of first, do no harm, and is not supported by standard obstetric practice, which advocates for a stepwise, evidence-based approach to management. A further incorrect approach might involve relying solely on patient self-assessment or anecdotal advice without incorporating objective clinical findings. While patient perception is important, it must be integrated with professional medical judgment and diagnostic tools to ensure accurate assessment and appropriate management, as expected by ABOG standards for evidence-based practice. Professional reasoning. Professionals should employ a structured decision-making framework when faced with concerns about fetal well-being. This framework begins with active listening and validation of the patient's concerns. Next, a thorough history should be obtained, focusing on the nature and timing of decreased fetal movements, as well as any associated maternal symptoms. This is followed by a comprehensive physical examination and objective assessment of fetal well-being using appropriate diagnostic tools, e.g., fetal heart rate monitoring, ultrasound. Based on these findings, a risk assessment should be performed, guiding the subsequent management plan, which may range from reassurance and education to further investigation or intervention. This systematic, evidence-based approach ensures that patient safety is paramount and that clinical decisions are well justified and aligned with professional standards. Question 4. Assessment of a 32-year-old patient with a history of premature ovarian insufficiency, POI, who presents seeking guidance on fertility preservation options. She reports irregular menses for the past 2 years, with episodes of amenorrhea lasting up to 3 months. She expresses a strong desire to have children in the future and is concerned about her declining fertility potential. What is the most appropriate initial approach to assess her current ovarian function and guide her fertility preservation strategy? Option A. Recommend oocyte cryopreservation without further diagnostic testing, given her age and POI diagnosis. Option B. Rely on the patient's subjective report of menstrual cycle regularity to gauge her current fertility status. Option C. Measure basal follicle stimulating hormone, FSH, estradiol. and anti-Mullerian hormone AM levels and perform an ultrasound for antral follicle count. Option D. Immediately initiate ovulation induction protocols to stimulate follicle development. The correct answer is C. Measure basal follicle stimulating hormone FSH, estradiol, and anti-Mullerian hormone AM levels and perform an ultrasound for antral follicle count. Explanation. Scenario analysis. This scenario presents a professionally challenging situation due to the inherent complexity of managing a patient with a history of premature ovarian insufficiency, POI, who is seeking fertility preservation. The challenge lies in accurately assessing residual ovarian function, predicting the likelihood of spontaneous conception, and guiding the patient toward appropriate fertility treatment options while respecting her reproductive autonomy and the evolving understanding of POI management. The physician must balance the patient's desire for future fertility with the biological realities of diminished ovarian reserve and the potential risks and benefits of various interventions. This requires a nuanced understanding of endocrinology, reproductive physiology, and current best practices in fertility preservation. Correct approach analysis. The correct approach involves a comprehensive evaluation that includes a detailed history, physical examination, and targeted laboratory assessments. Specifically, measuring basal follicle stimulating hormone FSH and estradiol levels, along with anti-Mullerian hormone AM, provides crucial objective data on the status of the hypothalamic pituitary ovarian axis and the remaining primordial follicle pool. AMH is particularly valuable as it correlates with the number of growing follicles and is less subject to diurnal variation than FSH. Ultrasound assessment for antral follicle count. AFCA offers a complementary visual assessment of ovarian reserve. This multifaceted approach aligns with the American Board of Obstetrics and Gynecology's emphasis on evidence-based practice and patient-centered care, ensuring that treatment decisions are informed by objective data and tailored to the individual patient's circumstances. It respects the ethical principle of beneficence by seeking to maximize the patient's chances of achieving her reproductive goals while minimizing unnecessary interventions. Incorrect approach is analysis. Relying solely on a patient's subjective report of menstrual cycles without objective hormonal assessment is an inadequate approach. Menstrual irregularity in POI can be variable, and spontaneous ovulation, while less likely, can still occur. Without objective data, the physician cannot accurately counsel the patient on her current fertility status or the urgency of fertility preservation. Failure to gather sufficient objective data violates the principle of non-maleficence by potentially delaying or omitting crucial fertility preservation options, thereby diminishing the patient's future reproductive potential. Prescribing ovulation induction agents without a thorough baseline assessment of ovarian reserve is also inappropriate. While ovulation induction can be a treatment for infertility, its efficacy is significantly influenced by the underlying ovarian status. In a patient with POI, the response to such agents may be poor, leading to frustration, financial burden, and potentially delaying more effective fertility preservation strategies like oocyte cryopreservation. This approach fails to adhere to the principle of judicious resource allocation and can be considered a breach of professional responsibility by offering a potentially ineffective treatment without adequate justification. Recommending immediate oocyte cryopreservation without assessing residual ovarian function and the possibility of spontaneous conception is premature. While oocyte cryopreservation is a valuable option for fertility preservation, it is an invasive and costly procedure. A thorough assessment may reveal that the patient still has a reasonable chance of conceiving naturally or with less aggressive interventions. Proceeding directly to cryopreservation without this assessment could lead to unnecessary patient anxiety and expense, and it bypasses a crucial step in shared decision-making, potentially undermining the patient's autonomy by not fully exploring all available options and their likelihood of success. Professional reasoning. Professionals should approach such cases by first establishing a comprehensive understanding of the patient's reproductive history and current concerns. This is followed by a systematic, evidence-based diagnostic workup to objectively assess ovarian reserve. The results of this assessment should then be discussed openly with the patient, outlining the probabilities of spontaneous conception, the benefits and risks of various fertility preservation and treatment options, and the potential impact of delaying intervention. Shared decision-making, grounded in accurate data and ethical principles, is paramount in guiding the patient toward the most appropriate course of action that aligns with her reproductive goals and values. Question 5. When evaluating a patient who expresses a strong preference for a less effective contraceptive method due to personal beliefs, but who also desires highly effective contraception to avoid pregnancy, what is the most appropriate course of action? Option A. Respect the patient's stated preference for the less effective method and provide it, assuming her beliefs are paramount to her decision-making. Option B. Recommend the most effective contraceptive method available, explaining its benefits, and strongly advise against the less effective method due to the increased risk of pregnancy. Option C. Refer the patient to another physician who may be more aligned with her contraceptive preferences, without providing detailed counseling on all options. Option D. Provide comprehensive counseling on all available contraceptive methods, discussing their respective efficacy, risks, and benefits, and explore the patient's underlying concerns to facilitate an informed, shared decision. Correct answer is D. Provide comprehensive counseling on all available contraceptive methods, discussing their respective efficacy, risks, and benefits, and explore the patient's underlying concerns to facilitate an informed, shared decision. Explanation. This scenario presents a common ethical dilemma in reproductive health care, requiring a physician to balance patient autonomy with the physician's professional responsibility to provide accurate and comprehensive information. The challenge lies in navigating a patient's deeply held personal beliefs that may conflict with evidence-based medical recommendations for effective contraception. The physician must ensure the patient's decision-making is informed and voluntary, while also upholding the standards of care. The correct approach emphasizes shared decision-making and patient-centered counseling. It involves actively listening to the patient's concerns, exploring the underlying reasons for her preferences, and providing clear, unbiased information about all available contraceptive methods, including their efficacy, risks, and benefits. This approach respects the patient's autonomy by empowering her to make an informed choice that aligns with her values and circumstances. It also adheres to ethical principles of beneficence and non-maleficence by ensuring the patient receives the most effective and safest options for her needs, even if those options differ from her initial stated preference. The American Board of Obstetrics and Gynecology, ABOG standards, implicitly support this by promoting comprehensive patient education and respect for individual patient values within the framework of evidence-based medicine. An incorrect approach would be to dismiss the patient's concerns or to impose a particular contraceptive method based on the physician's own judgment of what is best, without adequate exploration of the patient's perspective. For instance, solely focusing on the patient's stated preference for a less effective method, without exploring her reasons or offering information about more effective options, would be a failure to provide adequate counseling and could lead to unintended pregnancy, violating the principle of beneficence. Another incorrect approach would be to refuse to discuss certain methods due to personal or institutional bias, which infringes upon the patient's right to information and autonomy. Failing to document the counseling process and the patient's informed decision would also be a professional failing, hindering accountability and continuity of care. The professional decision-making process in such situations should involve 1. Active listening and empathy to understand the patient's values and concerns. 2. Providing comprehensive, evidence-based information about all relevant contraceptive options. 3. Exploring the patient's understanding of the information and addressing any misconceptions. 4. Facilitating a shared decision-making process where the patient's preferences are central within the bounds of safe and effective medical practice. 5. Documenting the discussion and the patient's informed choice. Question 6. Process analysis reveals a patient presenting with concerns about irregular spotting between periods. While discussing potential causes, the clinician recognizes an opportunity to enhance the patient's understanding of her reproductive endocrinology. Which of the following approaches best facilitates patient comprehension and empowers her to actively participate in her healthcare decisions regarding her menstrual cycle? Option A. Assess the patient's current understanding of the menstrual cycle phases and then provide a tailored explanation of the follicular, ovulatory, luteal, and menstrual phases, correlating hormonal changes with potential symptoms and fertility. Option B. Provide the patient with a standard brochure detailing the menstrual cycle and advise her to read it at her convenience. Option C. Briefly mention that spotting can occur during different phases of the menstrual cycle without elaborating on the specific phases or hormonal influences. Option D. Explain the hormonal fluctuations using complex scientific terminology, assuming the patient possesses a background in reproductive endocrinology. The correct answer is A. Assess the patient's current understanding of the menstrual cycle phases and then provide a tailored explanation of the follicular, ovulatory, luteal, and menstrual phases, correlating hormonal changes with potential symptoms and fertility. Explanation. Scenario analysis. This scenario presents a common clinical challenge where a patient's understanding of their menstrual cycle phases is incomplete, leading to potential misinterpretation of symptoms and suboptimal management of reproductive health. The challenge lies in accurately assessing the patient's knowledge, providing clear and evidence-based education, and ensuring that this education is tailored to her specific needs and concerns, all within the framework of patient autonomy and informed consent. Correct approach analysis. The correct approach involves a comprehensive assessment of the patient's understanding of menstrual cycle phases, followed by patient-centered education that clarifies the hormonal and physiological changes occurring during each phase. This approach aligns with best practices in patient care, emphasizing clear communication and shared decision-making. It adheres to the American Board of Obstetrics and Gynecology, ABOG, guidelines which prioritize evidence-based education and patient empowerment. By explaining the follicular, ovulatory, luteal, and menstrual phases, and relating them to potential symptoms or fertility, the clinician ensures the patient can make informed decisions about her health, reproductive choices, and symptom management. This respects the patient's right to understand her own body and participate actively in her care. Incorrect approaches analysis. One incorrect approach involves simply providing a generic pamphlet on the menstrual cycle without assessing the patient's current knowledge or addressing her specific questions. This fails to meet the standard of individualized patient care and may not effectively convey the necessary information, potentially leading to continued misunderstanding. Ethically, it can be seen as a failure to adequately inform the patient, undermining the principle of informed consent. Another incorrect approach is to assume the patient has a basic understanding and only address her immediate symptom without contextualizing it within the menstrual cycle. This misses a crucial opportunity for patient education and can lead to a fragmented understanding of reproductive health. It deviates from best practice by not providing a holistic view of the patient's physiology. A third incorrect approach is to use overly technical jargon without simplification, assuming the patient will understand complex endocrinological terms. This creates a barrier to communication and can lead to confusion and frustration, hindering the patient's ability to engage with her healthcare. It violates the ethical principle of clear communication and can be seen as a failure to provide understandable medical information. Professional reasoning. Professionals should approach patient education by first actively listening to the patient's concerns and assessing their existing knowledge base. This is followed by a clear, concise, and individualized explanation of relevant physiological processes, using language appropriate for the patient's comprehension level. The goal is to foster understanding, empower the patient to make informed decisions, and build a trusting therapeutic relationship. This process ensures that care is not only clinically sound, but also ethically robust, respecting patient autonomy and promoting optimal health outcomes. Question 7. The assessment process reveals a 32-year-old G2P1001 at 41 weeks gestation, attempting a vaginal birth after a prior low transverse cesarean delivery for fetal distress. She has been in active labor for 18 hours, with the last 3 hours in the second stage. Cervical dilation is 10 cm, but fetal station is at -1, with minimal descent noted with contractions. Fetal heart rate monitoring shows intermittent late decelerations, which are resolving with maternal repositioning and oxygen. The patient is becoming fatigued. What is the most appropriate management strategy? Option A. Continue expectant management with frequent fetal monitoring and encourage maternal rest, anticipating spontaneous descent. Option B. Administer oxytocin augmentation to stimulate more forceful contractions and encourage further fetal descent. Option C. Proceed with cesarean delivery due to prolonged second stage, lack of fetal descent, and intermittent late decelerations in the setting of a VBAC attempt. Option D. Attempt operative vaginal delivery with forceps given full dilation and the patient's desire to avoid a repeat cesarean. The correct answer is C. Proceed with cesarean delivery due to prolonged second stage, lack of fetal descent, and intermittent late decelerations in the setting of a VBAC attempt. Explanation: this scenario presents a common yet critical clinical challenge in obstetrics, managing a prolonged second stage of labor in a patient with a history of prior cesarean delivery. The professional challenge lies in balancing the desire for vaginal birth after cesarean VBAC with the increasing risks associated with prolonged labor, particularly uterine rupture. Careful judgment is required to assess fetal well-being, maternal exhaustion, and the likelihood of successful vaginal delivery versus the risks of intervention. The correct approach, which involves a thorough assessment of fetal well-being, maternal status, and labor progress, followed by a discussion of risks and benefits with the patient leading to a decision for cesarean delivery, represents best professional practice. This aligns with guidelines from organizations like the American College of Obstetricians and Gynecologists, ACOG, which emphasize shared decision-making and the importance of timely intervention when labor progress is inadequate or fetal distress is suspected, especially in the context of a VBAC attempt. The decision to proceed with cesarean delivery in this situation is supported by evidence indicating increased risks of uterine rupture and other adverse outcomes with prolonged second stages in VBAC patients. An incorrect approach would be to continue with expectant management without a clear plan for intervention, particularly if fetal heart rate abnormalities are present or if the patient is showing signs of exhaustion. This could be considered a failure to adhere to standards of care for fetal monitoring and management of prolonged labor, potentially violating ethical obligations to prevent harm. Another incorrect approach would be to proceed with an operative vaginal delivery, e.g., forceps or vacuum extraction, without a clear indication or adequate assessment of the risks, especially given the prior cesarean. This could increase the risk of maternal trauma and fetal injury. It may not be appropriate if the primary concern is the risk of uterine rupture. A third incorrect approach would be to unilaterally decide on a cesarean delivery without adequate discussion and shared decision-making with the patient, which undermines patient autonomy and the principles of informed consent. Professional decision-making in such situations requires a systematic approach. First, assess the immediate clinical picture: fetal heart rate, maternal vital signs, cervical dilation, effacement, station, and descent. Second, consider the patient's history and preferences, particularly regarding VBAC. Third, consult relevant clinical guidelines and evidence-based literature. Fourth, engage in open and honest communication with the patient and her support system, discussing the risks and benefits of continued labor, operative vaginal delivery, and cesarean delivery. Finally, make a timely and evidence-based decision that prioritizes maternal and fetal safety. Question 8. Upon reviewing the chart of a 45-year-old patient with a strong family history of ovarian cancer, mother and sister diagnosed in their 50s, and a history of abnormal Papanicolau smears managed conservatively, which of the following approaches best aligns with current best practices for gynecological cancer surveillance and management in the United States? Option A. Proceed with a total hysterectomy and bilateral salpingo-oophorectomy to proactively mitigate the risk of future gynecological malignancies. Option B. Advise the patient that since she is asymptomatic, no further investigation or surveillance is immediately necessary beyond routine age-appropriate screening. Option C. Initiate genetic counseling and consider germline genetic testing for hereditary cancer syndromes, alongside enhanced surveillance protocols for ovarian and endometrial cancer based on established guidelines. Option D. Schedule annual pelvic examinations and transvaginal ultrasounds, as this is standard practice for women in this age group with a history of abnormal Pap smears. The correct answer is C. Initiate genetic counseling and consider germline genetic testing for hereditary cancer syndromes, alongside enhanced surveillance protocols for ovarian and endometrial cancer based on established guidelines. Explanation: this scenario presents a professional challenge due to the nuanced differences in management and surveillance protocols for gynecological cancers, particularly concerning the evolving understanding of risk stratification and the application of evidence-based guidelines. The physician must navigate patient-specific factors, potential genetic predispositions, and the latest recommendations from authoritative bodies to ensure optimal patient care and adherence to established standards of practice. The correct approach represents best professional practice because it integrates a comprehensive assessment of the patient's individual risk factors, including family history and potential genetic mutations, with current evidence-based guidelines for surveillance and management of gynecological cancers. This aligns with the principles of personalized medicine and the ethical obligation to provide care that is both effective and tailored to the patient's unique circumstances. Adherence to established guidelines, such as those from the American College of Obstetricians and Gynecologists, ACOG, or the National Comprehensive Cancer Network, NCCN, ensures that diagnostic and therapeutic interventions are delivered in a manner consistent with the highest standards of care and regulatory expectations for patient safety and quality. An incorrect approach that relies solely on age-based screening, without considering a strong family history of ovarian cancer, fails to acknowledge the significantly increased risk associated with hereditary predispositions. This oversight could lead to delayed diagnosis and suboptimal outcomes, potentially violating the ethical duty to provide diligent and thorough care. Another incorrect approach that immediately recommends aggressive surgical intervention without a definitive diagnosis or consideration of less invasive options, such as genetic counseling and targeted surveillance, may be premature and could lead to unnecessary morbidity and patient distress, failing to adhere to the principle of least harm and appropriate resource utilization. A third incorrect approach that dismisses the patient's concerns due to a lack of overt symptoms, despite a concerning family history, represents a failure in active listening and a disregard for the potential for asymptomatic disease progression, which is a critical ethical and professional failing in cancer care. Professional decision-making process for similar situations should involve a systematic evaluation of the patient's presenting concerns, a thorough review of their medical and family history, and an assessment of their individual risk profile. This should be followed by consultation with relevant, up-to-date clinical guidelines and, when appropriate, multidisciplinary team input. The physician must then engage in shared decision-making with the patient, clearly explaining the risks, benefits, and alternatives of various management strategies, ensuring that the chosen course of action is both medically sound and aligned with the patient's values and preferences. Question 9. During the evaluation of a 32-week gestation pregnancy, serial ultrasounds have shown a persistent discrepancy between estimated fetal weight and gestational age norms, with the estimated fetal weight falling below the 10th percentile. The patient is a nulliparous woman with no significant medical history. What is the most appropriate next step in managing this situation? Considering the principles of fetal development and growth assessment as guided by the American Board of Obstetrics and Gynecology. Option A. Immediately recommend induction of labor due to concerns about potential fetal compromise. Option B. Focus solely on maternal nutritional status and recommend aggressive dietary supplementation without further fetal assessment. Option C. Reassure the patient that fetal growth can vary significantly and defer further investigation unless the discrepancy becomes more pronounced. Option D. Initiate a comprehensive assessment of fetal well-being, including non-stress testing and amniotic fluid index, and schedule close follow-up with serial ultrasound to monitor growth and Doppler studies to assess placental function. The correct answer is D. Initiate a comprehensive assessment of fetal well-being, including non-stress testing and amniotic fluid index, and schedule close follow-up with serial ultrasounds to monitor growth and Doppler studies to assess placental function. Explanation. Scenario analysis. This scenario is professionally challenging because it requires the clinician to balance the patient's autonomy and informed consent with the objective assessment of fetal well-being and the potential implications of findings on future management. The clinician must navigate the complexities of communicating potentially concerning information without causing undue alarm, while also ensuring that the patient understands the significance of the findings and the rationale behind recommended follow-up. The inherent uncertainty in interpreting fetal growth parameters and the potential for subjective bias necessitate a rigorous and evidence-based approach. Correct approach analysis. The correct approach represents best professional practice by prioritizing a comprehensive and objective assessment of fetal development and growth. This involves utilizing standardized growth charts, considering all relevant clinical data, maternal history, ultrasound parameters, and engaging in shared decision-making with the patient. The American Board of Obstetrics and Gynecology, ABOG guidelines emphasize evidence-based practice and patient-centered care. Therefore, a thorough review of all available data, consultation with colleagues if necessary, and clear communication with the patient about findings and management options aligns with a BOG commitment to high-quality obstetric care and patient safety. This approach ensures that decisions are grounded in established medical knowledge and respect the patient's right to participate in her care. Incorrect approach is analysis. One incorrect approach would be to dismiss the findings as insignificant without a thorough investigation. This fails to adhere to the ABOG expectation of diligent clinical evaluation and could lead to misdiagnoses of fetal growth restriction or other developmental abnormalities, potentially impacting fetal outcomes. Ethically, it breaches the duty of care to the fetus and the patient. Another incorrect approach would be to overemphasize the findings and recommend immediate, aggressive interventions without sufficient evidence or consideration of the patient's individual circumstances. This could lead to unnecessary anxiety for the patient and potentially iatrogenic complications. It deviates from the principle of do no harm and fails to respect patient autonomy by not fully exploring less invasive options or the natural variability in fetal growth. A third incorrect approach would be to rely solely on a single measurement or parameter without considering the broader clinical context. Fetal growth is a dynamic process, and isolated findings can be misleading. This approach lacks the comprehensive evaluation expected by a BOG and could result in misinterpretation of the fetal growth trajectory. It also fails to engage in the nuanced clinical reasoning required for optimal patient management. Professional reasoning. Professionals should approach such situations by first gathering all relevant data, including maternal health, previous obstetric history, and all available ultrasound measurements. They should then compare these findings to established growth standards and consider potential confounding factors. Open and honest communication with the patient, explaining the findings, their potential implications, and the rationale for any recommended follow-up or management is paramount. This process should be iterative, allowing for adjustments based on new information or the patient's evolving understanding and preferences, always within the framework of evidence-based medicine and ethical patient care as espoused by a BOG. Question 10. Risk assessment procedures indicate a 32-week gestation patient with preeclampsia is exhibiting intermittent late decelerations on fetal monitoring, with a non-stress test showing minimal variability and occasional accelerations. The maternal fetal medicine specialist is considering the optimal management strategy. Which of the following approaches best aligns with current best practices for managing potential fetal compromise in this scenario? Option A. Continue expectant management with serial non-stress tests every 24 hours, as the accelerations suggest adequate fetal oxygenation. Option B. Perform a biophysical profile and umbilical artery Doppler studies to further assess fetal well-being before making a definitive management decision. Option C. Initiate immediate delivery via cesarean section due to the presence of late decelerations and minimal variability, as these are concerning signs of fetal hypoxia. Option D. Administer antenatal corticosteroids and await spontaneous labor, as the gestational age is approaching viability. Correct answer is C. Initiate immediate delivery via cesarean section due to the presence of late decelerations and minimal variability, as these are concerning signs of fetal hypoxia. Explanation. This scenario presents a professional challenge due to the inherent uncertainty in predicting fetal outcomes and the ethical imperative to provide timely and appropriate care based on evolving clinical information. The physician must balance the potential risks of intervention against the risks of expectant management, all while adhering to established guidelines for maternal-fetal medicine practice. Careful judgment is required to interpret complex fetal monitoring data and integrate it with maternal clinical status. The correct approach represents best professional practice because it prioritizes a systematic, evidence-based evaluation of fetal well-being. This involves utilizing all available diagnostic tools, including non-stress tests and biophysical profiles, to assess fetal oxygenation and reserve. The decision to proceed with delivery is then based on objective findings indicating fetal compromise, aligning with the American College of Obstetricians and Gynecologists (ACA) guidelines, which emphasize timely intervention when fetal distress is suspected or confirmed, thereby minimizing the risk of adverse neonatal outcomes. This approach is ethically sound as it acts in the best interest of the fetus. An incorrect approach would be to delay intervention solely based on a single reassuring non-stress test, despite other concerning clinical signs. This fails to acknowledge the dynamic nature of fetal well-being and could lead to a missed opportunity to prevent fetal hypoxia. Ethically, this constitutes a failure to act with due diligence. Another incorrect approach would be to proceed with delivery based on maternal anxiety alone, without objective fetal monitoring evidence of compromise. This represents an overintervention, potentially exposing the neonate to the risks of prematurity or unnecessary operative delivery without clear medical indication, violating the principle of do no harm. Finally, failing to consult with a maternal fetal medicine specialist when faced with complex or equivocal findings would be a regulatory and ethical failure, as it deviates from best practice for managing high-risk pregnancies and could lead to suboptimal decision-making. Professional reasoning in such situations requires a structured approach. First, thoroughly assess all available data, including maternal history, current clinical status, and fetal monitoring results. Second, consider the differential diagnosis for any observed abnormalities. Third, consult relevant guidelines and, if necessary, seek expert consultation. Fourth, communicate clearly with the patient and her family about the findings, risks, benefits, and proposed management plan. Finally, document all assessments, decisions, and communications meticulously. Question 11. Consider a scenario where a nulliparous patient at 39 weeks gestation is in active labor. The fetal heart rate tracing shows recurrent late decelerations with minimal variability. The patient is requesting an epidural for pain management, and the obstetrician is evaluating the fetal status. Which of the following management strategies best reflects current American Board of Obstetrics and Gynecology recommendations for intrapartum fetal monitoring and management? Option A. Administer maternal oxygen and intravenous fluids, and then reevaluate the fetal heart rate tracing in 30 minutes before considering any further interventions. Option B. Proceed with epidural placement while continuing to monitor the fetal heart rate tracing closely, and prepare for potential operative delivery if the pattern does not improve or worsens. Option C. Delay epidural placement until the fetal heart rate tracing shows improvement, and continue to observe the patient expectantly. Option D. Immediately proceed to operative delivery without further assessment, as late decelerations with minimal variability are definitive signs of fetal distress. The correct answer is B. Proceed with epidural placement while continuing to monitor the fetal heart rate tracing closely, and prepare for potential operative delivery if the pattern does not improve or worsens. Explanation. This scenario presents a common yet complex challenge in labor and delivery, requiring a physician to balance maternal and fetal well-being with patient autonomy and established clinical guidelines. The core difficulty lies in interpreting fetal heart rate, FHR, tracings, which can be ambiguous, and making timely decisions that have significant implications for both mother and baby. The physician must consider the potential risks of intervention, e.g., operative delivery, versus the risks of continued labor with a concerning FHR pattern. Adherence to ABOG-recommended standards for intrapartum fetal monitoring and management is paramount. The correct approach emphasizes a systematic evaluation of the FHR tracing, considering baseline rate, variability, accelerations, and decelerations in conjunction with clinical context. This aligns with ABOG guidelines that stress the importance of a comprehensive assessment rather than focusing on isolated FHR findings, promptly initiating interventions based on a clear understanding of the FHR pattern and its implications for fetal oxygenation, while also communicating effectively with the patient and team, represents best professional practice. This approach prioritizes patient safety and adherence to evidence-based medicine, minimizing the risk of adverse perinatal outcomes. An incorrect approach that relies solely on the presence of decelerations without considering their type, frequency, or relationship to uterine contractions fails to meet the standard of care. This could lead to unnecessary interventions, increasing maternal morbidity, or, conversely, to delayed intervention when fetal distress is present, potentially resulting in poor neonatal outcomes. Another incorrect approach that delays intervention despite clear signs of evolving fetal compromise, perhaps due to hesitancy or misinterpretation, constitutes a failure to act in the best interest of the fetus and mother, violating ethical obligations and potentially regulatory requirements for appropriate medical management. A third incorrect approach that proceeds with operative delivery without a thorough assessment of the FHR tracing and clinical context, or without adequate communication with the patient and team, demonstrates a lack of systematic decision-making and can lead to iatrogenic complications. Professional decision-making in such situations requires a structured approach. First, meticulously analyze the FHR tracing in its entirety, categorizing it according to established criteria e.g., Category I, Roman II, or Roman III. Second, integrate this interpretation with the clinical picture, including maternal vital signs, labor progress, and any other relevant factors. Third, consider the potential benefits and risks of various management options, including continued observation, maternal positioning, oxygen administration, or operative delivery. Fourth, communicate clearly and effectively with the patient, obtaining informed consent for any proposed interventions, and with the labor and delivery team to ensure coordinated care. Finally, document the assessment, rationale for decisions and interventions thoroughly. Question 12. The review process indicates a 36-week pregnant patient presence with bilateral lower extremity edema, which has gradually worsened over the past 2 weeks. She denies headache, visual changes, or epigastric pain. Her blood pressure is 130/80 mmHg, and a dipstick urinalysis shows trace protein. Which of the following represents the most appropriate initial management strategy? Option A. Reassure the patient that mild edema is a common physiological change in late pregnancy, continue routine prenatal care, and instruct her to report any new or worsening symptoms, particularly those suggestive of preeclampsia. Option B. Immediately admit the patient to the hospital for serial blood pressure monitoring, laboratory evaluation for HELLP syndrome, and consideration of magnesium sulfate administration. Option C. Prescribe a diuretic to reduce fluid retention and recommend strict bed rest to decrease venous pressure. Option D. Schedule an urgent ultrasound to assess fetal well-being and a Doppler study of the lower extremities to rule out deep vein thrombosis. The correct answer is A. Reassure the patient that mild edema is a common physiological change in late pregnancy, continue routine prenatal care, and instruct her to report any new or worsening symptoms, particularly those suggestive of preeclampsia. Explanation. Scenario analysis. This scenario presents a common clinical challenge in obstetrics where a pregnant patient exhibits symptoms that could indicate a serious complication. Professional challenge lies in accurately interpreting these findings within the context of normal pregnancy physiology to avoid unnecessary interventions, while ensuring timely management of potential pathology. The physician must balance the patient's well-being with the risks associated with diagnostic and therapeutic measures. Correct approach analysis. The correct approach involves a systematic evaluation that considers the physiological adaptations of pregnancy, specifically understanding that mild edema, particularly in the lower extremities, is a common and often benign finding in late pregnancy due to increased venous pressure and fluid retention, is crucial. This approach prioritizes a thorough history and physical examination, including assessment of blood pressure, proteinuria, and reflexes, to rule out preeclampsia, a significant maternal and fetal risk. If these assessments are reassuring, expectant management with close monitoring is the best professional practice, aligning with guidelines for managing common pregnancy discomforts and avoiding iatrogenic harm. This reflects a commitment to evidence-based practice and patient safety, as mandated by the American Board of Obstetrics and Gynecology's focus on competent and ethical patient care. Incorrect approaches analysis. One incorrect approach would be to immediately initiate aggressive diagnostic testing or treatment for a condition like preeclampsia based solely on the presence of mild edema. This fails to acknowledge the physiological changes of pregnancy and could lead to unnecessary anxiety for the patient, costly and potentially invasive investigations, and even iatrogenic complications from premature interventions. This approach violates the principle of judicious medical practice and could be seen as a failure to adhere to established diagnostic algorithms for common obstetric conditions. Another incorrect approach would be to dismiss the edema entirely without a comprehensive assessment. While mild edema is common, it can also be an early sign of more serious conditions such as preeclampsia, deep vein thrombosis, or cardiac issues. Failing to perform a thorough evaluation, including vital signs and urinalysis, represents a deviation from standard obstetric care and could result in delayed diagnosis and management of a potentially life-threatening condition, which is a significant ethical and professional failing. Professional reasoning. Professionals should employ a decision-making framework that begins with a comprehensive understanding of normal pregnancy physiology. This is followed by a systematic assessment of the patient's signs and symptoms, comparing them against known physiological changes and potential pathological deviations. The framework emphasizes ruling out serious conditions with appropriate, minimally invasive diagnostic steps before resorting to more aggressive interventions. This approach ensures patient safety, promotes efficient resource utilization, and upholds the ethical obligation to provide appropriate and evidence-based care. Question 13. Which approach would be most appropriate when a pregnant patient, with no contraindications to vaginal birth and no emergent medical indications for cesarean delivery, expresses a strong, persistent desire for an elective cesarean delivery? Option A. Schedule an elective cesarean delivery as requested by the patient to respect her autonomy and avoid potential conflict. Option B. Engage in a detailed discussion with the patient about her reasons for requesting a cesarean delivery. Thoroughly explain the established medical indications for cesarean birth according to American Board of Obstetrics and Gynecology guidelines, and collaboratively explore her concerns and fears, offering education and support for vaginal birth. Option C. Proceed with a cesarean delivery without extensive discussion, documenting it as a patient-requested procedure to avoid further patient dissatisfaction. Option D. Refuse to consider a cesarean delivery and strongly advocate for vaginal birth, emphasizing the risks of surgery without providing a comprehensive discussion of her concerns. The correct answer is B. Engage in a detailed discussion with the patient about her reasons for requesting a cesarean delivery. Thoroughly explain the established medical indications for cesarean birth according to American Board of Obstetrics and Gynecology guidelines, and collaboratively explore her concerns and fears, offering education and support for vaginal birth. Explanation. Scenario analysis. This scenario presents a common yet complex clinical challenge where a patient's request for a cesarean delivery conflicts with the physician's assessment of medical necessity. The challenge lies in balancing patient autonomy with the physician's duty to provide evidence-based care and avoid unnecessary surgical intervention, which carries inherent risks. Navigating this requires a thorough understanding of established indications for cesarean delivery and the ethical principles governing patient-physician relationships. Correct approach analysis. The correct approach involves a comprehensive discussion with the patient, exploring her reasons for requesting a cesarean delivery, addressing her fears and concerns, and clearly explaining the established medical indications for cesarean birth as per American Board of Obstetrics and Gynecology, ABOG, guidelines. This approach upholds patient autonomy by engaging in shared decision-making, while simultaneously adhering to professional standards that mandate cesarean delivery only when medically indicated to ensure maternal and fetal well-being. It prioritizes evidence-based practice and patient safety by avoiding a procedure without a clear medical rationale, thereby minimizing potential surgical complications. Incorrect approaches analysis. Electively performing a cesarean delivery solely based on maternal request without a documented medical indication, as outlined by ABOG standards, constitutes a failure to adhere to evidence-based medical practice and potentially violates the principle of non-maleficence by exposing the patient to surgical risks without commensurate benefit. Similarly, dismissing the patient's concerns and refusing to engage in a thorough discussion about her request, without exploring the underlying reasons or offering alternatives, undermines patient autonomy and the physician's ethical obligation to provide patient-centered care. Forcing a vaginal delivery against a patient's informed refusal, even if medically indicated, would also be ethically problematic and could lead to legal ramifications, though the primary focus here is on the indication for cesarean. Professional reasoning. Professionals should approach such situations by first actively listening to and validating the patient's concerns. A detailed discussion should then ensue, covering the risks and benefits of both cesarean delivery and vaginal birth, specifically in the context of the patient's individual circumstances and current medical knowledge. The physician must clearly articulate the established indications for cesarean delivery according to ABOG guidelines, emphasizing that it is a major surgical procedure reserved for situations where vaginal birth poses a greater risk to the mother or fetus. If the patient's request stems from fear or misinformation, providing accurate education and exploring strategies to mitigate those fears during labor is paramount. If, after thorough discussion and education, the patient continues to request a cesarean delivery without a clear medical indication, the physician must document the discussion. the patient's understanding, and the rationale for either proceeding with or declining the request, potentially involving consultation with colleagues or ethics committees if the situation remains complex. Question 14. System analysis indicates a 28-year-old nulliparous woman presents with a 12-month history of amenorrhea and a chief complaint of infertility. She reports no significant medical history, denies recent weight changes or excessive exercise, and has no galactorrhea. Her last menstrual period was over a year ago. She is concerned about her ability to conceive. What is the most appropriate initial diagnostic step to evaluate the disorders of her hypothalamic pituitary ovarian axis? Option A. Perform a diagnostic laparoscopy to assess ovarian morphology. Option B. Initiate empiric oral contraceptive therapy to regulate cycles. Option C. Order a thyroid-stimulating hormone TSH level and a pregnancy test only. Option D. Measure serum follicle-stimulating hormone FSH, luteinizing hormone LH, estradiol and prolactin levels. The correct answer is D. Measure serum follicle-stimulating hormone FSH, luteinizing hormone LH, estradiol and prolactin levels. Explanation. Scenario analysis. This scenario presents a professionally challenging situation due to the potential for misdiagnosis and inappropriate treatment of a complex endocrine disorder. The patient's symptoms are nonspecific and can overlap with various conditions, necessitating a thorough and systematic diagnostic approach. The challenge lies in differentiating between primary ovarian insufficiency, hypothalamic dysfunction, and other potential causes of amenorrhea and infertility, while also considering the patient's age and desire for future fertility. Careful judgment is required to avoid premature conclusions and ensure a comprehensive evaluation aligned with current medical standards and ethical considerations. Correct approach analysis. The correct approach involves a stepwise diagnostic process that begins with a detailed history and physical examination, followed by targeted laboratory investigations. This approach is best professional practice because it systematically rules out common causes and then delves into more complex etiologies. Specifically, assessing follicle-stimulating hormone, FSH, luteinizing hormone LH, estradiol, and prolactin levels provides crucial information about the functional status of the hypothalamic pituitary ovarian axis. Further evaluation with thyroid-stimulating hormone, TSH, and potentially adrenal androgens is indicated to exclude other contributing endocrine disorders. This methodical approach ensures that the diagnosis is accurate, leading to appropriate management strategies that address the underlying cause and optimize the patient's health and reproductive potential, adhering to the principles of evidence-based medicine and patient-centered care. Incorrect approaches analysis. An approach that immediately initiates empiric hormonal therapy without a thorough diagnostic workup is professionally unacceptable. This fails to identify the root cause of the amenorrhea and infertility, potentially masking a serious underlying condition or leading to ineffective treatment. Ethically, it violates the principle of beneficence by not ensuring the patient receives the most appropriate care based on a confirmed diagnosis. It also risks iatrogenic complications from unnecessary hormonal interventions. Another incorrect approach would be to solely focus on ovarian function tests without considering the upstream regulatory components of the HPO axis. This overlooks the possibility of hypothalamic or pituitary dysfunction, which would require a different management strategy. This diagnostic limitation could lead to a delayed or incorrect diagnosis, impacting the patient's long-term health and fertility prospects. It represents a failure to adhere to comprehensive diagnostic guidelines. A third incorrect approach would be to dismiss the patient's concerns or attribute symptoms solely to psychological factors without a thorough endocrine evaluation. This is ethically problematic as it can lead to patient dissatisfaction and a failure to address a potentially treatable organic cause. It also demonstrates a lack of professional diligence and adherence to the standard of care for evaluating reproductive endocrine complaints. Professional reasoning. Professionals should approach such cases by first establishing a comprehensive understanding of the patient's history, including menstrual cycles, sexual development, and any relevant medical conditions. A thorough physical examination should then be conducted. The diagnostic process should be guided by a tiered approach, starting with basic hormonal assessments and progressing to more specialized tests as indicated by the initial findings. This systematic method ensures that all potential causes are considered and investigated appropriately, leading to an accurate diagnosis and personalized treatment plan. Ethical considerations, including informed consent, patient autonomy, and the principle of non-maleficence, must be integrated into every step of the decision-making process. Question 15. The risk matrix shows a patient presenting with secondary amenorrhea. To accurately determine the underlying cause of her menstrual cycle dysfunction, which of the following diagnostic strategies best reflects a systematic evaluation of hormonal regulation? Option A. Measure serum progesterone and estradiol levels to assess ovarian function. Option B. Measure serum thyroid-stimulating hormone TSH and free T4 levels to rule out thyroid dysfunction. Option C. Measure serum follicle-stimulating hormone FSH, luteinizing hormone LH, estradiol and prolactin levels. Option D. Initiate empirical treatment with a progestin challenge test to evaluate for anovulation. The correct answer is C. Measure serum follicle-stimulating hormone FSH, luteinizing hormone LH, estradiol and prolactin levels. Explanation. This scenario presents a professional challenge because it requires a physician to interpret complex hormonal feedback loops in the context of a patient's reproductive health, specifically addressing amenorrhea. The challenge lies in accurately diagnosing the underlying cause by differentiating between central and peripheral hormonal dysregulation, which has significant implications for treatment and long-term management. Careful judgment is required to avoid misdiagnosis and inappropriate therapeutic interventions. The correct approach represents best professional practice because it systematically evaluates the hypothalamic pituitary ovarian (HPO) axis by assessing the levels of key hormones at specific points in the cycle. This aligns with established diagnostic algorithms for amenorrhea, which prioritize identifying the source of the hormonal imbalance. By measuring FSH and LH, the physician can differentiate between primary ovarian insufficiency, high FSH/LH, and hypothalamic or pituitary dysfunction, low or normal FSH/LH. Subsequent assessment of estradiol and prolactin further refines the diagnosis, guiding appropriate management strategies that are evidence-based and patient-centered, adhering to the principles of good medical practice as expected by the American Board of Obstetrics and Gynecology. An incorrect approach that focuses solely on peripheral hormone levels without assessing the central regulators, hypothalamus and pituitary, fails to address the root cause of the amenorrhea. For instance, solely measuring estradiol without considering FSH and LH would miss a primary pituitary or hypothalamic issue. This is a regulatory and ethical failure as it deviates from standard diagnostic protocols, potentially leading to delayed or incorrect treatment and failing to provide the standard of care. Another incorrect approach might involve empirical treatment without a clear diagnosis. This is professionally unacceptable as it is not evidence-based, risks adverse effects from unnecessary medications, and fails to meet the ethical obligation to diagnose before treating. It also represents a failure to adhere to the rigorous standards of practice expected by the American Board of Obstetrics and Gynecology, which emphasizes diagnostic accuracy. The professional decision-making process for similar situations should involve a thorough patient history and physical examination, followed by a systematic diagnostic workup guided by established clinical guidelines for amenorrhea. This includes understanding the feedback mechanisms of the HPO axis and selecting appropriate hormonal assays based on the clinical presentation. The physician must critically evaluate the results of these tests in conjunction with the patient's symptoms to arrive at an accurate diagnosis, thereby ensuring safe and effective management. Question 16. The investigation demonstrates a couple presenting with a history of unexplained infertility after 1 year of unprotected intercourse. The male partner has no significant past medical history. The physician is considering the next steps in their fertility workup. Which of the following approaches best aligns with the established regulatory framework and guidelines for the American Board of Obstetrics and Gynecology in evaluating male reproductive function? Option A. Initiate a detailed semen analysis including sperm count, motility, and morphology, and consider a hormonal evaluation e.g. FSH, LH, testosterone, if initial semen parameters are significantly abnormal. Option B. Recommend empirical testosterone supplementation for the male partner to improve sperm production without further diagnostic testing. Option C. Immediately proceed with in vitro fertilization if, to maximize the chances of conception, given the duration of unexplained infertility. Option D. Focus the diagnostic workup exclusively on the female partner, as male factor infertility is less common. The correct answer is A. Initiate a detailed semen analysis, including sperm count, motility, and morphology, and consider a hormonal evaluation, e.g., FSH, LH, testosterone, if initial semen parameters are significantly abnormal. Explanation. Scenario analysis. This scenario presents a professional challenge in managing a patient's fertility concerns within the context of evolving diagnostic capabilities and established clinical guidelines. The physician must balance the patient's desire for information and potential treatment with the ethical and regulatory considerations surrounding the use and interpretation of advanced reproductive technologies and genetic testing. The challenge lies in providing accurate, evidence-based counseling while respecting patient autonomy and adhering to the American Board of Obstetrics and Gynecology, ABOG standards, which emphasize patient safety, informed consent, and appropriate use of medical resources. Correct approach analysis. The correct approach involves a comprehensive evaluation of the male partner's reproductive function, including a detailed semen analysis and consideration of hormonal profiling, if indicated by the initial findings. This aligns with ABOG guidelines that advocate for a systematic and evidence-based approach to infertility investigations. The focus on established diagnostic modalities ensures that interventions are guided by reliable data, minimizing unnecessary procedures and associated risks. Furthermore, offering genetic counseling and testing, when indicated by semen analysis results, e.g., severe oligozoospermia or azoospermia, is crucial for identifying potential underlying causes and informing reproductive planning, which is a key aspect of comprehensive reproductive health care as supported by ABOG principles. Incorrect approaches analysis. Proceeding directly to assisted reproductive technologies, ART, without a thorough initial semen analysis and hormonal assessment is premature and deviates from standard infertility workup protocols. This approach risks incurring significant financial and emotional burdens on the couple without a clear understanding of the underlying cause of infertility, potentially violating principles of judicious resource utilization and informed decision-making. Recommending empirical hormonal therapy without objective evidence of a hormonal imbalance, as indicated by appropriate blood tests, is not supported by current ABOG guidelines. Such an approach can lead to adverse effects, mask underlying issues, and delay definitive diagnosis and treatment, thereby failing to meet the standard of care. Focusing solely on the female partner's reproductive health while neglecting a complete evaluation of the male partner's contribution to infertility is an incomplete diagnostic strategy. ABOG standards emphasize a couple-centered approach to infertility, requiring a thorough assessment of both partners to identify all contributing factors and guide appropriate management. Professional reasoning. Professionals facing similar situations should employ a systematic, evidence-based decision-making process. This begins with a thorough patient history and physical examination, followed by a stepwise diagnostic approach guided by established clinical guidelines, such as those provided by ABOG. When interpreting diagnostic results, physicians must consider their implications for both immediate management and long-term reproductive health, including potential genetic factors. Patient counseling should be clear, comprehensive, and tailored to the individual couple's circumstances, ensuring informed consent for all proposed investigations and treatments. Ethical considerations, including patient autonomy, beneficence, and non-maleficence, must guide every step of the clinical encounter. Question 17. Process analysis reveals that a laboring patient, at 6 cm dilation and 7/10 cervical change per hour, expresses a strong desire for a specific analgesic agent she received in a previous labor, stating it was highly effective. The current clinical scenario presents no immediate contraindications to common labor analgesia, but the patient's request is for a medication that, while generally safe, has a slightly higher risk profile for maternal sedation and potential impact on fetal heart rate variability compared to other available options at this specific stage of labor. The clinical team must determine the most appropriate course of action. Option A. Discuss the patient's previous positive experience with the requested agent. Review the current risks and benefits of that agent in the context of her current labor progress. Explore alternative pain management strategies and collaboratively decide on the best approach for her current labor. Option B. Offer a non-pharmacological pain management technique as the primary option, deferring any pharmacological interventions until the patient's pain becomes unmanageable. Option C. Decline the patient's request for the specific analgesic agent, citing the slightly increased risk profile, and proceed with a different, lower-risk pain management option without further discussion. Option D. Administer the requested analgesic agent immediately, given the patient's strong preference and previous positive experience, to ensure her comfort and satisfaction. The correct answer is A. Discuss the patient's previous positive experience with the requested agent. Review the current risks and benefits of that agent in the context of her current labor progress. Explore alternative pain management strategies, and collaboratively decide on the best approach for her current labor. Explanation. This scenario is professionally challenging because it requires balancing a patient's expressed desire for a specific pain management modality with the clinician's professional judgment regarding its safety and efficacy in the context of evolving labor progress and potential complications. The American Board of Obstetrics and Gynecology, ABOG, emphasizes evidence-based practice and patient-centered care, which necessitates a thorough understanding of available pain relief options, their indications, contraindications, and potential side effects, all within the framework of U.S. regulatory guidelines and ethical principles. The correct approach represents best professional practice because it prioritizes a shared decision-making process that is grounded in a comprehensive assessment of the patient's current clinical status and a clear explanation of the risks and benefits of all available pain management options. This aligns with the ethical principle of autonomy, ensuring the patient is fully informed and can make a decision that respects her values and preferences, while also upholding the clinician's responsibility to provide safe and effective care as guided by established medical standards and guidelines. This approach ensures that the patient's request is considered within the broader context of her well-being and the safety of both mother and fetus, adhering to the principles of beneficence and non-maleficence. An incorrect approach that involves immediately administering the requested medication without a thorough reassessment of the patient's labor progress or a discussion of alternatives fails to meet the standard of care. This could lead to adverse maternal or fetal outcomes if the medication is not appropriate for the current stage of labor, or if there are contraindications that were not identified. Ethically, this bypasses the informed consent process, violating patient autonomy. Another incorrect approach, to dismiss the patient's request outright without adequate explanation or exploration of alternatives, demonstrates a lack of patient-centered care and can erode trust, potentially leading to patient dissatisfaction and a failure to adequately address her pain experience. This also neglects the clinician's duty to explore all reasonable avenues for pain relief. A third incorrect approach, to proceed with a less effective or potentially riskier alternative without a clear rationale or patient agreement, also undermines informed consent and may not adequately address the patient's pain, leading to suboptimal labor experience and potential complications. Professional decision-making in such situations should involve a systematic process. First, thoroughly assess the patient's current clinical condition, including labor progress, fetal well-being, and vital signs. Second, actively listen to and acknowledge the patient's preferences and concerns regarding pain management. Third, clearly explain the available pain relief options, including their mechanisms of action, expected benefits, potential side effects, and contraindications, tailored to the patient's specific situation. Fourth, engage in shared decision-making, discussing the pros and cons of each option in relation to the patient's current status and preferences. Finally, document the discussion, the decision made, and the rationale for the chosen course of action. Question 18. Performance analysis shows that a 32-year-old G2P1 patient at 38 weeks gestation is experiencing a sudden onset of severe vaginal bleeding and abdominal pain during labor. Fetal monitoring reveals severe bradycardia with minimal variability. The patient appears pale, diaphoretic, and hypotensive. The obstetric team recognizes the signs of a potential placental abruption with significant hemorrhage. Which of the following actions best represents the appropriate management in this critical obstetric emergency, adhering to the principles of patient care and professional responsibility within the U.S. regulatory framework? Option A. Administer intravenous fluids and oxytocin to manage the bleeding and pain, and continue to monitor the fetal heart rate closely, awaiting further changes before considering operative intervention. Option B. Delay all interventions for at least 15 minutes to allow for a comprehensive discussion with the patient regarding the risks and benefits of all potential interventions, including the possibility of expectant management. Option C. Immediately initiate emergency cesarean delivery to attempt to save the fetus and control maternal hemorrhage, while simultaneously arranging for a nurse to obtain verbal consent from the patient or her designated surrogate if she is unable to communicate, documenting the emergent nature of the situation. Option D. Proceed with immediate surgical intervention without any attempt to obtain consent, assuming that the emergent nature of the situation obviates the need for patient input. The correct answer is C. Immediately initiate emergency cesarean delivery to attempt to save the fetus and control maternal hemorrhage, while simultaneously arranging for a nurse to obtain verbal consent from the patient or her designated surrogate if she is unable to communicate, documenting the emergent nature of the situation. Explanation. This scenario presents a professionally challenging situation due to the rapid deterioration of a patient's condition during labor, requiring immediate and decisive action to ensure maternal and fetal well-being. The challenge lies in balancing the need for swift intervention with the imperative to adhere to established protocols and ethical considerations, particularly regarding informed consent and patient autonomy, even in emergent circumstances. The correct approach represents best professional practice because it prioritizes immediate life-saving measures for both mother and fetus, while simultaneously initiating the process of obtaining informed consent as soon as feasible. This aligns with the American Board of Obstetrics and Gynecology's emphasis on evidence-based management of obstetric emergencies, which includes prompt recognition, timely intervention, and clear communication. The principle of beneficence, acting in the patient's best interest, and non-maleficence, avoiding harm, are paramount. In a life-threatening situation, the physician has a duty to act to preserve life, and obtaining consent, while crucial, can be obtained retrospectively or with assent from a surrogate if the patient is incapacitated, provided the intervention is clearly indicated and life-saving. This approach respects patient autonomy to the greatest extent possible under duress. An incorrect approach that involves delaying critical intervention to obtain full, detailed, informed consent from a patient who is rapidly deteriorating and potentially unable to comprehend or consent meaningfully would be a failure of the physician's duty to act. This would violate the principle of beneficence and could lead to irreversible harm or death, constituting a significant ethical and professional failure. Similarly, proceeding with a non-emergent intervention without attempting to obtain any form of consent or assent, or without documenting the emergent nature of the situation and the inability to obtain consent, would be a regulatory and ethical breach. This disrespects patient autonomy and could expose the physician to legal and professional repercussions. Another incorrect approach would be to perform an intervention that is not clearly indicated by the emergent clinical picture, even if consent is obtained, as this would violate the principle of non-maleficence and could be considered battery. Professional decision-making in such situations requires a rapid assessment of the clinical urgency, a clear understanding of the potential benefits and risks of immediate intervention versus delay, and a commitment to communicating with the patient or their surrogate as effectively as the situation allows. The physician must be prepared to document the emergent nature of the circumstances, the rationale for the chosen course of action, and any attempts made to obtain consent or assent. This framework emphasizes prioritizing life-saving measures when necessary, while always striving to uphold patient rights and ethical obligations. Question 19. Risk assessment procedures indicate a term neonate is born limp and apneic. Following initial drying and stimulation, the neonate remains apneic with no improvement in tone. What is the most appropriate immediate next step in management according to established neonatal resuscitation guidelines? Option A. Initiate positive pressure ventilation. Option B. Focus on reassuring the parents while observing the neonate. Option C. Administer epinephrine intravenously. Option D. Perform a complete physical examination to identify potential causes of apnea. The correct answer is A. Initiate positive pressure ventilation. Explanation. This scenario is professionally challenging due to the rapid deterioration of a neonate requiring immediate intervention, coupled with the need to adhere to established resuscitation guidelines while managing parental presence and anxiety. The physician must balance the urgency of the situation with the ethical imperative of informed consent and family-centered care. The correct approach represents best professional practice by prioritizing immediate, evidence-based neonatal resuscitation, according to the American Academy of Pediatrics Neonatal Resuscitation Program, NRP, guidelines. This includes a systematic assessment of the neonate's condition, respiratory effort, heart rate, tone, and the initiation of appropriate interventions such as positive pressure ventilation, PPV, and chest compressions if indicated. The prompt and accurate administration of PPV is crucial for improving oxygenation and ventilation, which are the primary goals in neonatal resuscitation. This aligns with the regulatory framework of the AAP/NRP, which is the standard of care in the United States for neonatal resuscitation, and is implicitly the framework for the American Board of Obstetrics and Gynecology exam. An incorrect approach that involves delaying PPV to first attempt a full physical examination before initiating resuscitation would be a significant regulatory and ethical failure. The AAP/NRP guidelines explicitly state that if a neonate is apneic or has gasping respirations, PPV should be initiated immediately without a full examination. Delaying PPV can lead to irreversible hypoxic-ischemic brain injury, violating the ethical principle of beneficence and the regulatory requirement to provide timely and appropriate care. Another incorrect approach, such as administering epinephrine before attempting PPV, would also be a failure. Epinephrine is indicated for bradycardia that persists despite adequate ventilation and chest compressions, not as a first-line intervention for respiratory distress. This deviates from the established algorithm and could be detrimental to the neonate, representing a failure to adhere to the regulatory framework of the NRP. Finally, an approach that focuses solely on parental reassurance without initiating resuscitation would be a critical failure. While parental support is important, it cannot supersede the immediate life-saving interventions required for the neonate. This would violate the ethical duty to preserve life and the regulatory expectation of providing competent medical care. The professional decision-making process in such a situation should follow a structured approach. 1. Rapidly assess the neonate's condition based on the initial presentation, e.g., term gestation, tone, breathing/crying. 2. Immediately initiate resuscitation steps as dictated by the NRP algorithm, prioritizing airway and breathing. 3. Continuously reevaluate the neonate's response to interventions. 4. Communicate effectively with the resuscitation team and, as appropriate with the parents, providing clear and concise updates. 5. Document all interventions and the neonate's response accurately. Question 20. Compliance review shows that a couple presents for evaluation of infertility after 1 year of unprotected intercourse without conception. The physician's initial approach to the evaluation and management plan is being assessed. Which of the following initial steps best reflects current best practices and regulatory guidelines for infertility evaluation in the United States? Option A. Advise the couple to continue trying for another 6 months before initiating any formal evaluation, citing the variability in conception timelines. Option B. Focus solely on the female partner's reproductive health, ordering hormonal assays and a hysterosalpingogram, while deferring any evaluation of the male partner. Option C. Initiate a comprehensive evaluation of both partners, including a detailed history and physical examination for each, followed by basic semen analysis for the male partner and assessment of ovulatory function and tubal patency for the female partner, along with counseling on lifestyle factors and timing of intercourse. Option D. Immediately refer the couple for in vitro fertilization if a consultation, given the duration of infertility, without performing an initial diagnostic workup. The correct answer is C. Initiate a comprehensive evaluation of both partners, including a detailed history and physical examination for each, followed by basic semen analysis for the male partner and assessment of ovulatory function and tubal patency for the female partner, along with counseling on lifestyle factors and timing of intercourse. Explanation. Scenario analysis. This scenario presents a professional challenge due to the inherent complexity of infertility evaluation and management, which requires a delicate balance between patient autonomy, evidence-based medicine, and adherence to established clinical guidelines and ethical principles. The physician must navigate potential patient emotional distress, varying levels of health literacy, and the financial implications of treatment. all while ensuring comprehensive and appropriate care. The challenge lies in providing a thorough evaluation that addresses all potential contributing factors to infertility without causing undue patient burden or anxiety, and in presenting management options that are both medically sound and aligned with the patient's values and goals. Correct approach analysis. The correct approach emphasizes a systematic and individualized evaluation, beginning with a detailed history and physical examination. This is crucial for identifying potential underlying causes of infertility, such as ovulatory dysfunction, tubal factors, or male factor infertility, as outlined by the American College of Obstetricians and Gynecologists, ACOG guidelines. The inclusion of basic semen analysis for the male partner is a cornerstone of initial infertility workup, as male factors contribute to approximately 40–50% of infertility cases. This aligns with the principle of providing comprehensive care to both partners in a couple experiencing infertility. Furthermore, offering appropriate counseling regarding lifestyle modifications and the timing of conception is a vital component of patient education and empowerment, ensuring patients are informed participants in their care. Incorrect approaches analysis. One incorrect approach might involve solely focusing on the female partner's evaluation without a concurrent assessment of the male partner. This violates the principle of a holistic approach to couples' infertility and fails to adhere to standard diagnostic protocols that recognize the significant contribution of male factors. It represents a failure to provide complete and evidence-based care as recommended by professional bodies. Another incorrect approach could be the immediate recommendation of advanced reproductive technologies without a thorough initial evaluation. This bypasses essential diagnostic steps, potentially leading to unnecessary expense, emotional distress for the patient, and overlooking simpler, more conservative treatment options. It also fails to meet the ethical obligation to provide care that is medically indicated and proportionate to the patient's needs. A third incorrect approach might involve delaying or omitting essential counseling on lifestyle factors and the impact of age on fertility. This neglects a critical aspect of patient education and management, as lifestyle choices and reproductive age significantly influence conception rates and treatment outcomes. It represents a failure to provide comprehensive patient support and education, which is a key ethical and professional responsibility. Professional reasoning. Professionals should approach infertility evaluation and management by first establishing a strong rapport with the patient, and conducting a thorough, systematic assessment. This involves gathering a detailed medical, surgical, and reproductive history, performing a comprehensive physical examination, and then proceeding with appropriate diagnostic tests based on the initial findings and established guidelines. The decision-making process should be collaborative, involving shared decision-making with the patient regarding diagnostic pathways and treatment options, always prioritizing evidence-based practice, patient safety, and ethical considerations. Professionals must remain current with the latest ACOG guidelines and other relevant professional recommendations to ensure the highest standard of care.